Hi, everybody. This is Dr. Jonathan Meyer, Voluntary Clinical Professor of Psychiatry at the University of California, San Diego, here to talk about the non-renal adverse effects of lithium. And in case you had any doubt, patients don't like adverse effects. And sadly, there are certain ones in particular which lead to discontinuation of lithium. A 2018 paper from Sweden gave us a sense of which ones in particular are very important and should be attended to immediately. Sadly, what we see overall is a picture of individuals not persisting with lithium. Among the 873 new starts to lithium in this region of Sweden, 54% stopped. But among those, it was 62% due to adverse effects, with the two most common ones being diarrhea at 13% and tremor at 11%. We're going to talk about some common adverse effects. And first, let's start with the GI ones. So nausea, not a big cause for discontinuation, but people don't like it. We think pathophysiologically that lithium ion delivered in the jejunum, in the small intestine, is what causes the sensation of nausea. It's not a central problem, it's a GI problem, and specifically a more upper GI problem. The prevalence ranges from 5% to 20%. But this is one which is managed by looking at two aspects. The first one is whether the patient is on a sustained release preparation. If they are on a regular lithium, which is delivering ion a little more proximally, we can maybe make the problem better by going to a sustained release preparation. Again, we always give lithium once a day, but by giving it as a sustained release form, we kind of delay the absorption a little bit, so not as much ion is being given all at once to the jejunum. This sometimes helps the problem with nausea. If that doesn't solve the trick, then we have taking it with dinner. This often mitigates a lot of the GI side effects and will instruct people to take lithium with food at dinner. Diarrhea represents, in many ways, the opposite problem. The ion is being delivered too far south. So in this instance, we also have a sense that higher levels, meaning higher exposure to lithium, also contributes to the problem. We have a range of estimates from 6% to 28% in the literature, but the way we approach this is the opposite of nausea. In this instance, if they're on a sustained release preparation, we would want to go back to standard lithium, meaning I want to move ion delivery further north and away from the colon. If they're already on standard lithium, then the next step is to have them take it with the dinner. The third approach, which is more nuanced, is to look at their levels and decide together with the patient, especially if the current level is in the high end of the therapeutic range, between zero point 0.8 and 1, if they could do just as well with a slightly lower level. The last one, of course, has to be taken into context with how they responded to levels which are below zero point 0.8, but it's something to look at if the other steps haven't helped. Tremor is something we all experience. Every time you have too much coffee, you have an exaggeration of your physiologic tremor, and that's exactly what lithium does. The frequency of this is 8 to 12 hertz, and it's a postural tremor, rarely noted at rest, but noted when you're holding, especially your hands against gravity. There's two components to this tremor. There's a central one, which gives it the frequency of 8 to 12 hertz, and there's also a peripheral reflex mechanical oscillation. And it's the peripheral component in particular, which is made worse by sympathomimetics, alcohol withdrawal, too much caffeine. The prevalence is quite broad in the older literature, but fortunately a fairly modern study with lithium compared to aripiprazole for maintenance of bipolar 1 randomized people to either a higher lithium level or a lower one. And we saw that the people who had a lithium level in the range of 0.8 to 1 had a tremor prevalence which was double those in the lower range of 0.4 to 0.6, 36% high level versus 18% low level. How do we manage this problem? Well, firstly, because the mechanical peripheral components are worsened by stimulants, norepinephrine reuptake inhibitors, caffeine, we try to peel those back as much as we can. Also be mindful of the fact that other mood stabilizers, especially valproate, can cause a similar tremor. So you may have an additive tremor from both the combination of valproate and lithium. Also, differentiate the tremor caused by lithium from that caused by antipsychotics. Drug-induced Parkinsonism is more seen at rest. It's a coarser tremor. It has a lower frequency of 3 to 7 hertz. And unlike lithium, it responds to anti-Parkinsonian agents. And then also look at the level itself. People with higher levels, as we illustrated, have more risk of tremor. And as we talked about with diarrhea, perhaps the patient can do just as well psychiatrically with a slightly lower level. The treatment of choice, though, when you need a medication is a beta blocker, and we prefer propranolol because propranolol has excellent CNS penetration. It's going to treat both the central component as well as the peripheral component. The literature is actually somewhat sparse in terms of controlled studies for lithium-related tremor, but this is paralleled by the robust literature on propranolol for the exact same problem, namely essential tremor. In that case, it's caused genetically, not by a drug, but same type of tremor, and the effect size you can see is 0.50. Because of the short half-life of propranolol, you have to dose it BID. Once you can get to a dose of 60 milligrams, there are extended release preparations which can be given once per day. The side effects of propranolol relate to the central properties, primarily fatigue, tiredness, but once in a while you also run into orthostasis as well. If the CNS effects become limiting, you can try a peripherally acting beta blocker such as atenolol. You lose the central effect, but you do treat the peripheral mechanical oscillation component, and for some people this might be sufficient. If beta blockers are not working out, and especially due to orthostasis, our last option with reasonable effect sizes is primidone. It is effective for both lithium and essential tremor. Effect size is 0.5 for essential tremor. It does have an active metabolite, but we think that contributes more to other anticonvulsant properties and doesn't really do much for the tremor. As many of you know, primidone also gets converted in part to phenobarbital. The reason why this is important to know is that phenobarbital is an inducer, so potentially this may affect the levels of certain antipsychotics, especially those who go through 3A4. It has a long half-life. Primidone should be titrated slowly to avoid ataxia and sedation. Typical starting dose is 100 milligrams at bedtime. Every few days, if tolerated, you can go up by increments of 50, with most people achieving response at doses of 250 milligrams at bedtime or below. If people experience fatigue or sedation, you have to back off on the titration. Do not titrate it rapidly. Most importantly, if you have to stop it, like other anticonvulsants, do not stop it abruptly because you may get withdrawal syndrome. Taper it off slowly to avoid any rebound effects. There's some other CNS complaints which are important, and again, people really don't like these, and especially cognitive slowing or complaints of emotional blunting. The hard part there is that you have to consider a lot of different variables before you decide it is the lithium. Is this person depressed? Are they on other medications, especially sedating medications? And lastly, is this somebody who likes the feeling of being hypomanic or manic and does not like the mood leveling effects of lithium? Once you've eliminated other causes, especially other medications and depression, you can talk about the fact with the patient that maybe they're getting a higher brain level than the next person for any given peripheral level. We know there's a lot of inter-individual variation in this, and you can talk together about maybe modestly reducing their lithium level to see if this makes the adverse effect better. We worry a lot as psychiatric practitioners about EKG changes, but for lithium, these are typically benign in non-overdose situations. Any ECG changes reflect the chronicity of lithium exposure, and it's working its way into myocytes and causing some benign changes like some PR interval prolongation, some T-wave changes, development of U waves, none of which present a source of cardiac death risk. These benign changes are not a reason to stop lithium. The rare time when you may have to stop lithium has to do with people in whom lithium unmasks sinus node dysfunction at therapeutic levels. These are people who have sick sinus syndrome and will actually require a pacemaker. In those circumstances, you will have to hold the lithium until they get their pacemaker placed for their sick sinus syndrome, and then lithium can be resumed. Skin and hair problems are an important issue partly because I cannot treat the problem immediately. I can give a medicine for tremor and maybe make it better within a few days. I cannot regrow hair quickly, neither can I treat acne very easily overnight. It's important to ask about these at every visit. By the time the patient complains spontaneously, if you haven't been asking, they are usually fed up and they want to stop the lithium. For hair loss, the approach is the same for men and women. It's topical minoxidil. Educate the women in particular that they will be prescribed the same strength as men, 5%. If they develop scalp irritation, or even if the man does, you can go to the lower strength. But at the pharmacy, both are available for men and women at 5% strength. Again, it works slowly. That's why you want to ask about it at every visit and start immediately as soon as the patient complains. Acne can be a particular problem with lithium. Lithium can exacerbate this. The initial strategies are all topical, first over-the-counter benzoyl peroxide, and then prescribed topical retinoids. If that doesn't work, or if they have other skin problems made worse by lithium, such as an exacerbation of psoriasis, this is the point when you want to refer them to a dermatologist. It's important you confer with the dermatologist beforehand and say, look, for this patient, stopping lithium is not the best option. Let's try to manage this person while they remain on lithium. Many of you know lithium is associated with hypothyroidism. We understand the mechanism. Lithium gets into the thyroid cell via transporter, which is normally transporting iodide. And there, the lithium tends to accumulate at levels 3 to 4 times that of plasma. The net effects include inhibition of release of both T4 and T3 from the thyroid gland. It also inhibits the formation of the active forms of T4 and T3 by interfering with the thyroglobulin coupling with the tyrosine residues, which are iodinated, and there may be alterations in the sensing of hypothalamic T4 and T3 centrally. Can you use lithium in somebody who has hypothyroidism per history? Absolutely. And most importantly, if somebody develops hypothyroidism on lithium, we never stop the lithium for this problem. It's one of the more easily managed adverse effects of lithium. The annual incidence varies. The best number I've seen is 1.5%, with a risk for women which is threefold greater than for men. But importantly, lithium does not cause other types of thyroid problems. Its use is not associated with anti-thyroid antibodies or development of thyroid tumors. People may develop Graves' disease or Hashimoto's thyroiditis on lithium, but at rates no different than the general population, and we do not stop lithium in those circumstances. But how do we manage the problem? Well, L-thyroxine is the treatment of choice. We don't stop the lithium. We do everything based on TSH. As you know, we monitor TSH roughly every 6 months. Here's the normal ranges. In routine clinical practice, most people often don't get treated until their TSH is 10 or above. But I think we started to recognize that some people are much more sensitive, even within the normal range, especially those with bipolar disorder. But there is a literature, even on individuals without bipolar disorder who are middle-aged, who have TSHs in the, quote, subclinical range of 4.5 to 9.9, who complain and have actually measurable cognitive effects and other nonspecific symptoms. But importantly for our bipolar patients, even if the level is high normal, if they're having trouble with depression, it may be due to the fact that they function better and have lower rates of depressive mood symptoms with TSH values which are in the lower end of the normal range. And I quote a study here from Mark Fry which showed that among lithium-treated patients who got treated for depression, they tended to have higher TSH levels than lithium-treated patients who did not require management of depressive symptoms. TSH is what you monitor. There's no reason to get ultrasounds, antibodies, or other laboratory measures beyond TSH. Once an abnormality is detected, then you might want to get a T4 or a T3. And again, there's debates even with the endocrine community about the value of those routinely or how we use this information. Do we look at the ratio of T4 to T3, T3 by itself? It is worth noting that this is something which you can discuss with an endocrinologist at times, especially when the TSH is normalized and maybe the T4 is normalized, but the T4 to T3 ratio is not where you'd want, and the patient complains of symptoms still. That may be something you can talk about. Should we maybe use some T3 augmentation to raise the T3 levels? That's really a higher level, more sophisticated discussion, but I want to present that information so you understand what the considerations are. Lithium also can affect the parathyroid gland, getting into places where it doesn't belong, and in this case, because it inhibits an enzyme GSK3-beta, important to its activity in the brain, but in this case, what it does is it alters the set point for parathyroid hormone suppression. The parathyroid gland, in the presence of lithium, now has its set point shifted to the right. So a higher serum calcium level is now required to suppress parathyroid hormone or PTH secretion. We monitor for this very easily by getting a serum calcium level every 6 months. What we know is that some people who are on chronic lithium therapy, there may be an increase in gland mass, but we think that what happens in some folks is that we're actually unmasking the development of either an adenoma or glandular hyperplasia. The reason this is important is that by the time we actually can see this on imaging, meaning hyperplasia or adenomas, this problem will likely persist even in the absence of lithium use, meaning lithium may have unmasked it, but it's going to persist even if you stop the lithium. The reason this is important to appreciate is that stopping lithium at that stage may be of little or no value. But even if gland mass is normal, we don't stop lithium for hypercalcemia or hyperparathyroidism. But what happens when you see a serum calcium level which is now elevated? Well, for one thing, you can see sporadic values which are above the upper limit of normal. So if you see one, just repeat it again, perhaps a bit sooner. If this is a persistent problem, the next test to order is an ionized calcium assay. Calcium is bound by albumin, so we look at the ionized calcium, which is the active portion, and there are norms for that as well. If this is above the upper limit of normal, the follow-up test is a parathyroid hormone. Once parathyroid hormone is abnormal, this is the point where you will refer to an endocrinologist for further workup and management. I give you the normal ranges here. It's important to know if people really do have significant chronic kidney disease, you will see an elevated parathyroid hormone, but those folks typically actually have low serum calciums. So generally, you would never be ordering a PTH unless the serum calcium is elevated. But I just wanted you to know that there's an association with elevated PTH values in chronic kidney disease. The workup that's done will be dictated by the endocrinologist. Mostly they want to look for other causes. Usually the cause is obvious, but they want to be complete. Importantly, though, lithium discontinuation is not necessary. Try to work with an endocrinologist if you can, who will not make reflexive demands to stop the lithium. This is like a hematologist who you refer to for something about clozapine who says stop the clozapine. It's not helpful. Typically, the problem can be managed while people remain on lithium. And as I mentioned before, once they get to the point where there's hyperplasia or adenomas, stopping lithium may be of little or no benefit anyhow. For people who are symptomatic, they get surgery. But most of the individuals we will pick up will be asymptomatic on the basis of an isolated serum calcium, which now remains persistent. There actually are surgical criteria for asymptomatic patients as well. The most important thing is if somebody needs surgery, go to a surgeon who does this type of surgery routinely. In many instances, people won't meet surgery criteria, they're poor surgical candidates, or they simply are not interested in surgery. We have an excellent option for them. there's a whole new class of agents which are called calcimimetics. These are drugs which actually stimulate the calcium sensing receptor and make it think that the serum calcium level is now higher. What it does is it now shifts that set point back to the left. And so the patients will now have suppression of PTH secretion at lower serum calcium levels. And there are case reports of it being used successfully, specifically for lithium-induced hyperparathyroidism. It's a great advantage that we have and a wonderful option for people who either are not surgical candidates or refuse surgery.